Thank you very much. I'm not sure where to stand. And does this work? Does this work? Okay. All right. So I didn't pick the title, just FYI. But what I'm going to do is just talk very broadly, and I'm basically going to take you through a consult of what I tell my patients as part of my natural spiel. And it's what I tell partners at the same time, because I think it's really important that I'm not an academic when I'm standing here talking to you about sexual health. So I want this to be relevant. If there's stuff that doesn't make sense and you want me to repeat, or you want to challenge anything I say, this is a place to do it. Again, it's a very open book, and nothing is out of bounds. At the same time, my job is not to make you feel uncomfortable about anything I talk about, all right? So this is a very, I usually say that I have nothing to disclose, not sponsored by any adult film companies. I don't sell sex toys. And you will never see me representing your favorite accoutrement. Okay? All right, so first a test, all right? And this is going to set the frame. I will be calling on people. If I make eye contact with you, I'm about to call on you. Rearrange these words. I'll give you 5 seconds. Okay. I see very concerned looks on people's faces. Did you get spine and subtext? Dirty, dirty, dirty. Neither did I. All right, now that it's sort of levity, this is what I want you to talk about, because sexual health, at the very end of the day, you have to find fun in it. It cannot be work. And unfortunately, a lot of folks after cancer, in their quest to rediscover themselves, feel it's something they just have to do. And that's not true. It's something you should want to do. It's something that you should want to enjoy. And it's not something that any one of you feels is the same thing. Right? So, why does this matter, and why is it a topic that we talk about here? It's because, like Susan Love coined, it is a very significant form of collateral damage. And it's not specific to breast cancer. If you go around and talk to folks with all sorts of types of malignancies, this is a major concern afterwards. And the reason for that spread, it depends on how we ask the question. Okay? If we say, are you having trouble with penetration? Some people will answer that absolutely. Some people will say no, because it's not something I do. If they say, are you having trouble with intimacy? You're going to get a different response, because intimacy is a pretty loaded term. All right, so your definition of intimacy may not match my definition of intimacy. And because of that, you're seeing this very large spread. But over half of folks, after a diagnosis of cancer and its treatment, it's affecting. And the reason it's so important is because none of us are alone in that. This is the Livestrong Survey, and I'm just going to take you through it. This was your survey. It was for people diagnosed with cancer before 40. Breast was represented, but so was colorectal, and so was lung. Sexual functioning and satisfaction was a third most commonly reported problem in this age group. And of those, so it's not working, is it? All right, I have to do the podium, but fortunately, I think you can see me. All right, good. No, it's all right. All right, so of those reporting sexual function, less than half of you or even getting help for it. And I think it's because it's so weird, you know. But if you think about what your medical oncologist talked to you about, right? How often are you going to the bathroom? Are you constipated? All right. Did you vomit today? All right. How far is that from asking someone, like, you know, how's your sex life? How is that different? It's a physical symptom, but we don't talk about it because I'll tell you the truth, we expect you to bring it up. All right. And why do we expect you to bring it up? It's because when we see men with prostate cancer or testicular cancer, they bring it up.
Of course they do.
Absolutely bring it up. But women are expected to do that. And when you do bring it up, it's not something medical oncologists are trained to handle. So they would, you know, it's something glossed over. And what we now, and what I tell my colleagues is, if you gloss over something like that, your patients, the people you're trying to help, will realize this is not something that is game. All right? But if it's important for you, then we need to address it, and I'm here to help you do that. Because you're not alone in this, and I see some partners in the room here. So if your issues in sexual health aren't addressed, it will spill outwards. It will affect your personal relationships. It'll affect how you recover from breast cancer. And it's associated with stigma, as well as depression, as well as anxiety. So again, your experience is not singular. Your experience is very much a shared one. And I think that is the first point where people breathe out. Because every single person I've ever spoken to about sexual health, it is so private, it is so personal, and it feels so solitary. All right? So it is not something that the minority of folks experience. Because sexual health isn't just about intercourse, especially true for women. It's about intimacy. It's about sensuality. It is about body image. It's about arousal, desire, climax, and satisfaction. All right? So when I use the term sexual health, I'm talking about a whole state that merges the physical and the social and the psychologic, because that's the experience of sexual health in women. It is not tied to any singular activity. So here's a true or false. After a diagnosis of cancer, so this is for the person diagnosed with cancer, men and women are impacted very similarly. Who thinks that's true? Okay, who thinks that's false? Okay, so who just doesn't really want to, who doesn't want to raise their hand? All right, good. So I'll put it another way, right? Is it really true that after cancer, women are from Venus and men are from Mars? The answer is, it's true. Cancer impacts men and women very differently. This is male sexual health. Okay. All right? And we know this is true because for men diagnosed with prostate cancer, it's fascinating. Men who are diagnosed with prostate cancer who cannot get erect cease to have any form of intimacy. That's the risk. Put it a way that I explain to my own patients. For men, the deepest form of intimacy is penetration. If you can't do that, why bother? If I can't go home, what's the point of going to first base? Okay? And there's a huge literature on that, of men just sort of backing away, even while their caregiver says, you know, if we just held hands, it would be enough. Men say, how could that possibly be enough? I don't feel like a man anymore. This is female sexual health. Okay? All right, I'm seeing some head nods. Yeah. So much like a computer, you turn it on and it just works. That was life before cancer for a lot of people. Okay? And then you turn on the computer and nothing happens. Or you hear some whirring, but the screen's black. And it just doesn't make sense. This is what cancer affects in women. All right? And there's no simple answer, but talking through exactly how the computer was working in the first place is part of what I think makes people feel better about trying to make it better today. So, what the hell happened, right? Because that's what everybody wants to know. This is Basson's model of female sexual health. Rosemary Basson was a gynecologist. She made up this model because she didn't feel like the other ones made sense. Masters and Johnsons, who literally took people into a lab and they had sex and they measured blood pressure changes, heart rate changes, and it was very based in the physiological experience of sex. Heart rate goes up, blood pressure goes up, breathing goes up, and then these things happen. She felt that this isn't sufficient, that there's really more to the story for women. So what she conceived is here. It's a propagating circle, and it starts at the point of intimacy. So the woman, when she's growing up, gets a sense internally that she wants and needs something more in her life. All right? That wakes up the body so that when things are touched a certain way, that's arousing. And with that awakening of arousal comes desire. And when desire is satisfied, you want to do it all over again. So what's missing in Basson's model? Intercourse. Masturbation. Okay? That's not here. The point is, your desire is not tied to an activity. This is why when you tell your partner, you know what's hot to me right now? You doing the dishes would be really hot right now. Okay? It's because at the very base of intimacy for women, we do not need an activity. We crave intimacy. You crave intimacy, right? You have desire, but what used to feel good may not feel good anymore. I want you to feel liberated by this picture, because your recovery will not be tied to your ability to have any activity that you used to enjoy together. It's not saying that you will never enjoy it again, but in your recovery, do not feel for both of you that this is still important. There's another thing I talked about earlier called breast-specific sensuality. This is some of the work that was done by a surgeon, Jennifer Goss. What she did was she took her panel of patients that were coming into a breast health center and just asked them simply, before you were diagnosed, before you had your surgery, how important was your chest to you sexually? Across the board, 80 to 90%. These were an erogenous zone. It falls by 10%, and if for those of you who had a mastectomy, it falls by 30%, where it's no longer a part of your sense of sexuality, and it is tied to your surgical outcome. Now, if you take the women who look most similar, so the women who had breast-conserving surgery or a lumpectomy, and you compare it to those women who had a mastectomy and reconstruction, and the only reason she did it is because they were similar in terms of their after-surgery experience. If you ask the question, is your breasts part of your sensuality today? Whether or not you had breast-conserving surgery or a reconstruction, 40% lose that sense that their breasts are a sensual organ. And if you ask, what is the experience when your chest wall, when your breasts are touched? 20% say it's unpleasant. And 28% after lumpectomy and half after reconstruction say it's anesthetic. I feel nothing when you touch it. So this is also something that I want you to put a name to, okay? Because partners, whether your partner's a woman or a man, okay, what used to be one of their triggers for you was your breasts. No one tells your partner that after breast cancer, it's not really going to work that way. And if it's one of the hardest conversations women tell me, they don't know how to say that to their partners. So what mechanisms do they do to cope? Sex only when the lights are off. I never have him touch my chest. I will only have sex with a shirt on. Okay? That's a real experience. And this name only came out in 2017, but there's a name for it. So when you go home, you say, these are not a sensual organ anymore. I sacrificed my breast's sensuality for my life. I think that's a way that partners can then understand and talk through that with you, okay? So the point of all of this is that things can absolutely get better, okay? Like I talked about yesterday, I counsel women in two very distinct ways. A medical aspect of health, vaginal health, also termed the genitourinary symptoms of menopause, the GSM, okay? I talk to women about the use of moisturizers. Then I talk to them about options therapeutically using laser, all right? And yes, for everyone in this room, I do talk about hormones, vaginal hormonal therapy, all right? Then I talk to folks about sexual health. And this is where it is to address ways to make penetrative activities enjoyable so that it isn't work. And I'm just going to pause right here for 1 second because I have to tell you, if you mirror any of my patients who are having penetrative intercourse because it's expected of you, because it was a pattern that you really, really need to continue for your own mental health so that you can feel connected despite the pain and because you think your husband expects it of you. That's okay. The reason that sexual health exists in cancer centers is because the experience is very different, right? So I'm not going to be the one with a sign up there saying, never go through pain, because you've gone through pain, right? And now you're just trying to recreate a sense of what's normal, all right? So I do talk about sexual health, and it's important for you to know that I encourage very much your partner to be a part of that conversation. Because one thing that is a myth, particularly about male partners after cancer, it is a myth that all men want is sex, especially in this group. I've had more than one male partner confess, because I don't know a better word for it, but confess that seeing someone they love, their other half, lose their hair, vomit, sometimes cleaning up after diarrhea, right? Seeing them so sick, almost die, right? And then be told you're cancer-free at the end. They need to sprint out of cancer land as fast as possible. They need to become normal. They need that emotionally. But every once in a while, some men get scared. And they're scared of the future. They have that fear of recurrence. They're scared, what if I lose you? And we don't give a voice to that. But in that sense of fear, some men need to have sex because the closest any male, and sometimes female really, but the closest a partner can be to a woman after breast cancer is inside of her. And it's the biggest sense of security sometimes a man can have. So it's not about just the need to get off after cancer. Okay? So whatever your assumptions are about your partner, I want you to question them as well. All right. How do we treat GSM? So this is the practical stuff that I'm getting to. So think of your vagina as part of your body, because it is, right? Yeah, I was like, yeah, that's an obvious moment, right? Yeah, thank you, Captain Obvious. Thank you. Yeah, see, you're wasting your time for Captain Obvious. Okay. So as such, we shampoo our hair, right? We put on moisturizers on our face almost daily, right? You need to do the same thing with your vagina. So vaginal moisturizers aren't a once a week thing if you're having pain, dryness, okay, or bleeding. Your vagina is incredibly dry. I can tell with an examination, all right? If that's an experience, vaginal moisturizers are the first line of recovery. You need a vaginal moisturizer 5 times a week. And you can even, Jesus Christ, really? 5 times a week, and even an hour before intercourse, all right? Different kinds are out there. Polycarbophilic base, otherwise known as Replens. You can even use vitamin E. You can even use natural oils externally. So vulva, you can use coconut oil. Don't apply it internally. If you don't want to do anything that possibly is chemical, there's something called Luvena. It's parabens free, all right? And none of these require a prescription. Okay, so go to Amazon.com. That's pretty much what I use on all of this, even when I was finding sex toys, because Amazon is not blocked by any server in any hospital, okay? So Luvena is a very good choice because it can also be used as a lubricant, okay? And just FYI, moisturizer is not a lubricant, okay? So we'll get to that as well. So what's the deal with vaginal laser therapy, otherwise known in some cases about Mona Lisa touch, right? All right, so this is microablative carbon dioxide laser therapy. It used to be used to treat wrinkles. Yeah. So this is some of the best data out there. It's in postmenopausal women with atrophy of the vulva and the vagina. It's usually rendered as 3 treatments done over 12 weeks. And it showed that it did improve function and help with both physical and mental quality of life. All right, so this is in women without cancer. This is the best data for women with cancer. All right, so this is an Italian study. He treated 50 women who had an oncologic menopause. All right, and there was no comparator here because it was just a singular experience with these 50 women. And he showed that using a visual analog scale, so that happy face all the way to the sad frowning face, women said it worked to help with pain with penetration. The term is dyspareunia, okay? So if you want to go, it's like, what's wrong with you? It's, you're talking in circles. You say, you don't have to say, it hurts when I have sex. You can say, I have dyspareunia. It's a good word. So it did help with dyspareunia. And I think the bigger bullet is the one in the end. It lasted for at least 11 months. Okay? So this is some of the best data. Now, I will also say that there's no randomized trial that I can say it's better than if you did X. Okay? It's also not covered by most insurance companies. But if you wanted to try to get it covered, I have had success if your doctor prescribes it as drug-induced female sexual dysfunction. Sometimes you can get insurance to cover that. It's not a guarantee. There's also a warning that was placed by the FDA on vaginal laser therapy for women because it might burn. It's a laser, right? But serious burns into the vagina have been reported. So go to someone experienced, go by word of mouth, go to people that other folks with cancer have used in the past. What about hormone therapy? For women with hormone receptor positive disease, that's a terrifying thing to think about. But I'm here to say that vaginal estrogen is safe. Vaginal estrogen is not the same thing as oral hormone therapy. The whole point is local exposure of estrogen into the vagina only, all right? So there's a little bit of data saying that you can increase estrogen levels if you take these drugs, but outcomes have never been shown to be decreased with vaginal estrogen. So for women who are not satisfied with the use of moisturizers, who are willing to try vaginal estrogen, I can look them in the eye and say, this will not increase your risk of a breast cancer recurrence, and it certainly will not affect your mortality. Okay? All right. So the American College of Obstetrics and Gynecology, this is their opinion. Use a non-hormonal approach first. If that doesn't work, you can prescribe vaginal estrogen therapy as part of a shared decision, all right? The data do not indicate I'm putting you at any risk at all as it relates to your cancer. This is very different from oral hormones, all right? So this, if your oncologist says you should never do it, it's because of this trial called Habits, okay? Hormone therapy after breast cancer, is it safe? The bottom line, they took women, randomly assigned them to a hormonal prep or to no hormones. If you have a uterus, it means estrogen with progesterone. If you don't have a uterus, you got estrogen because you don't need the progesterone. Because the biggest risk, right, for oral hormone therapy, if you just take estrogen, we will induce thickening of the uterine lining, which can turn into uterine cancer, okay? So uterus, they got estrogen, progesterone. Without a uterus, they got estrogen. The bottom line, there was a significantly increased risk of a breast cancer event on hormonal therapy. It was restricted to women with hormone-positive disease, but there was no impact on survival. So no one died on this study. However, the caveat is they only studied women for 3 years. Okay? So don't make heads or tails about that part. But this is still the reason why we don't recommend hormone therapy after breast cancer. There's a drug called aspamifene or Aspina. Has anybody heard of this drug? Okay. This is vaginal tamoxifen. All right? So it only works in the vagina. Okay, so it's indicated in postmenopausal women without a history of cancer who have atrophy because it also improves painful sex. This is what they're using in Europe for you. So if you are a breast cancer survivor and have trouble with pain with sex or atrophy, they're prescribing aspamifene. So why haven't you heard about this drug? It has a label that says you probably shouldn't use it in women with breast cancer because we just haven't studied you. And that's the problem with the literature in sexual health. You are not represented in the literature. Breast cancer was exclusionary in this study. This is another drug called DHEA. Has anybody heard of this? So this is on market. So dihydroepiandrosterone was studied in women with cancer against the placebo, and the bottom line is it did work. But it's interesting, so did the placebo. In fact, in studies on sexual health, 40% of people will get better on a placebo, okay? But compared to placebo, this also worked, all right? So this is also on market. Some people don't want to prescribe it to you because they are concerned DHEA will be converted to estrogen, all right? Although this study showed that that didn't happen in this panel, okay? So still a bit of controversy. Personally, I have no problems prescribing DHEA. But talk to your oncologist. So, any questions about GSM or vulvovaginal atrophy or, yeah?
Do you want the mic?
Yeah. Yeah, I can hear you. Yeah. Yeah, so the question was, if you're on these estrogen blockers, right, aren't you sort of defeating the purpose with vaginal estrogen?
Well, aren't you overcoming any risk with using, or is it kind of a protective benefit, with using these vaginal?
Well, so if you're on an aromatase inhibitor, right, so the way that works is not to block estrogen from seeing anything. It's to block you from producing it. That's how it works. So you're not supposed to be producing any estrogen on an aromatase inhibitor. Tamoxifen is blocking the cell from seeing the effects of estrogen. So what your point is very relevant on tamoxifen. Shouldn't matter, right? Because the drug is blocking breast cancer cells. But on an AI, the whole point is to just get rid of all of the estrogen in your body. Because even if you're postmenopausal, you're still making estrogen. If you wonder why man boobs thing is a real thing, it's because estrogen is converted from natural steroids in fat. Okay, so the aromatase is being blocked by the inhibitors. So when we introduce estrogen, we're actually defeating the purpose of the AI because we're introducing estrogen. But what I can say is that with vaginal estrogen, the doses today are so small, right? So, back in the day, it was like 50 to 100 micrograms of estrogen, right, just to get an effect. These vaginal tablets that one can place in their vagina, 10 micrograms. It's a very small dose. So we don't think there's a systemic release of estrogen that will negate the AIs.
So I've got a prescription sitting at the pharmacy for like the last couple of weeks.
Yeah.
That's scared me.
Yeah, and so I will say that. So I'm glad you said that because not everybody is willing to do estrogen. And my job is not to convince you to do it, all right? I need to work within your boundaries of, I need to do what's safe for me, and this is not it. I'm not supposed to make you feel guilty because you're robbing yourself of the one thing that's going to help you, because that's not true, okay? So if you don't want to use it, that's okay. But I don't want you to walk away from here thinking it's not an option for me because. Good. Yeah.
I already did Mona Lisa touch 4 times, and that didn't work.
Yeah.
So I'm very interested in doing the estrogen. Is that like a daily thing? Does it
Yeah.
matter that, like, if you take it every day, do you increase risk? Because I know that you're saying no. I guess I'm just worried about it putting it in my body. every
Right.
day.
So the typical prescription is 14 days, daily for 14 days, and then 2 to 3 times a week after that. I recommend you do that for 3 months and then stop and see how long the effect lasts, because it will last. And then sometimes women need to repeat that course, 4 to 5 months down the road, but so it's not an every day for 3 years kind of a thing. It's sort of like done and then we stop and then you go. Yeah.
How do you feel about the ring?
The estrogen ring. So we had this conversation the other day. I think it's okay, but I was corrected by one of the gynecologists at the MGH for a very good reason. Not all vaginal estrogens are local, all right? So make sure you understand the dose. It's very important to ask the question of what do we know about systemic levels after all these vaginal preparations, because there are vaginal hormone therapies where the goal is to give you that systemic dose. Okay, so that's the thing that I think is a little complicating. The only reason I use a 10 microgram tablet is A, it's the lowest dose out there, okay, so far, and also it's not messy, but the same thing can be said for the ring. Yeah. Yeah.
So I have triple negative cancer.
Yeah.
And my oncologist, I had hysterectomy, so I have these issues. And my oncologist was prescribing me estrogen. And I was like, oh, no, no. And he was like, you have triple negative cancer.
Yeah.
And he just kept saying that to me, I think because I was so freaked out about it. But even my girlfriend who's triple positive, she's also taking the estrogen.
Just estrogen alone? Or is she taking the combination? Yeah. So I will say, I actually don't think, okay, you're probably going to quote me on this one, sorry. I don't, phones down. I think the whole field of hormone replacement therapy is a bit of a mess. And you illustrated the point precisely. It matters whether or not you have a uterus. So way back in the day when they did something called the Women's Health Initiative Study, WHI, stopped early because hormones are associated with an increased risk of breast cancer. So giving women without a history of breast cancer oral hormone therapy increased their risk of breast cancer. That was only true for the combination, estrogen with progesterone. For women who didn't have a uterus like you, who were given estrogen only, the risk actually fell a little bit. Okay? So I'm okay with being on oral estrogen alone if you can do that. I'm not saying you should all get a hysterectomy, you can go on oral estrogen. But I'm less worried about that. And here's the other thing that's so interesting. Estrogen, for women with metastatic breast cancer, estrogen's a therapy. Yeah, crazy. But there's data that you can actually induce tumor regression with estrogen. Okay? So it's a little bit of a mess. It's a little complicated. I think I've oversimplified the data because I think it's the best way for getting the message out. But if you challenged me, just like, I'm triple negative and I don't have a uterus and my quality of life's really horrible, why can't I go on estrogen? I can't find the data specifically for you. So I think it's okay. Yeah.
To go back to the ring, is there a time limit? Because I've been using that for probably 5-7 years.
No.
That's something, because I've heard other people say you shouldn't only use it for short periods of time.
Yeah, I think as long as you're being seen by your gynecologist for it, and if you've been on it for 5 to 7 years and you're fine, it proves my point, Yeah, no, and then I think, again, I think estrogen-only preparations, I'm actually very comfortable prescribing them. But, oh, you don't? Oh, that's good. All right. Thumbs up, then. No, but, I think it's, well, let's go with that. That's fantastic. Yeah, and I think it's, I have patients who have said, if I don't get this, I can't function. You have to help me with this. So that's where the shared decisions come in, right? It's like, if you really need something, I want to make sure I counsel you about the risks and the benefits, and I want to make sure I counsel your partner as well, because this sexual health thing, there's more than just you in that picture, all right? But I think it's okay, as long as you're informed. It's the reason why some women chose a double mastectomy, right? It was a choice that you guys made after thinking about what you wanted to do. It's the same thing. All right. I don't know, how are we doing on time? All right, I have 15 minutes. Thanks a lot. Okay. So lubricants. Moving forward. There are two types. Okay, silicone and water-based. No preference was expressed in this one study I'm pointing here. For women who are doing penile anal intercourse, there's more of a preference for water-based lubricants. Big thing about lubricants, saliva, not a lubricant. Okay? All right. Okay, just to be clear, you can quote me on that. You can quote me on that. All right, good. See? Take a picture. Saliva is not a lubricant. Okay? Everybody take a picture. That's fine with me. Because it also says, make sure you get the penile anal intercourse bullet right there on the bottom. All right, good. All right. What about coconut oil? What about olive? Why can't I use an oil as lubricant? So the theoretical reason is that we're afraid it'll go rancid in your vagina. That's the theoretical reason. So, because I didn't sit at home thinking about it, I'm just telling you what the theoretical reason is. All right? This is what you're going to hear. All right? So you shouldn't use olive oil. It might go rancid. It's not, right? It's not cute when it goes cheesy and All right, I told you. Close the door, please, in the back. Close the door. So there was this one study called Overcome. I'll just point to this because I think it's very interesting. 25 women did this multidimensional study of pelvic floor therapy, olive oil for sex, and a moisturizer. If you look at the benefit of 12 weeks, 73% of folks loved using olive oil. And they didn't report rancidity as a toxicity of olive oil. This is the best data about the use of olive oil, okay? Okay, so this is the biggest news. So the situation here for vestibular tenderness, we're about to do it, everything feels great, and then it tries to enter me, and it's like knives. It's just knives trying to get through me, and I can't. It's so painful that we can't even I can't go further, all right? If you don't address that, your vagina will get very angry at you, okay? The point is, if you do a pelvic exam on women with vestibular tenderness, it literally is if you could take a Q-tip and just touch around the opening of the vagina, just the opening, it's tender. And if you try to insert fingers and dilate it to accommodate anything, women are arching their backs, tears are coming down their face. It hurts that much. If that is your experience, get a pelvic exam. This is a beautiful, simple study. Women were either given a placebo or they were given lidocaine, a very dilute form of lidocaine, applied with a cotton swab, 3 minutes onto the vestibule. And they were allowed to just do whatever came naturally. Look at the bottom bullet. Of 20 women not having intercourse because of pain, 95% were able to reclaim penetrative intercourse for them and their partners. And I can tell you truthfully, it works. Okay? So what?
Testimonial.
Yes. Preach. Yes. So, no, I can't explain how horrific it is for a woman who used to love penetration, used to be the basis of their relationship, to lose that and to come to me. I find this, give them a little bottle of lidocaine and instructions. Within 2 weeks, they're okay. They're okay. All right? My one piece of advice, and then I'll get to the question. Do not let your partner do it, at least the first couple of times, because oftentimes they overshoot the vestibule, and then all of a sudden there's numbness in the clitoris. Okay? All right? So literally, and if you need your doctor to explain how to do this, I do this all the time. Well, I show women with a mirror, all right? This is the vestibule. This is where it goes. It doesn't go all the way inside, all right? It just goes right on the vestibule, 3 minutes before penetration. And for partners, male partners, there's no anesthesia. Okay, so this is simply to help your woman get through that very, very difficult hurdle. Okay, and it's very effective. So we'll take a question in the back and then one in the very back.
Isn't this like kind of like, this isn't treatment, this is like putting a Band-Aid on?
No, actually, so that's a great question. So what I generally want you to envision is that your vagina is a smooth muscle, all right, that you can't control from the vestibule all the way into the vaginal vault, okay? So things that hurt, your vagina is going to spasm, okay? So as much as you want to relax, right? No, it's not relaxing you. No, it has nothing to do with you. This is all about your vagina. It's not about you. It's about her. Yeah. It's about teaching her that you're going to protect her. And it's about teaching her that this doesn't have to hurt. That this is teaching her that this used to be fun. And it's about reclaiming that. Because as much as, like I was saying, so as much as you want to relax, as much as your partner tells you, I wish you would relax so we could both enjoy this, your vagina's not going to relax. You cannot control your vagina. But you can teach her that you're going to be protective. So we'll get a question in the back and then one in the front.
I know with long-term use, lidocaine, sometimes it can cause heart arrhythmias.
Mm-hmm.
Has that been linked to this type of usage?
So very important question. Make sure it's the most dilute form of lidocaine that you're getting. Here, did I write it? It's 4% aqueous lidocaine. So that's 4 milligrams of lidocaine in 100 milliliters of fluid. It is incredibly dilute. So it's not like you're going to feel anesthesia for 3 days later. Okay? This is a very dilute form. We have not reported any cardiac arrhythmias in the studies of this, and it's not used every day. Well, you know, you could use every day, but it's not used every day. It's very much an as-needed option. Yeah.
Thank you.
Yeah. There was a question in the front. Yep.
Is it kind of like use it or lose it, and it helps you get to the use it part?
So that's interesting. So I will say, do not ever feel you'll lose it. Yeah, you never lose it. Okay, it's there if you want it, though. Okay, but it's more about I want to use it, and I really want to use it. Yeah. Good question.
As far as like the lubricants, have you ever heard of using sesame oil?
Sesame oil? I haven't. I haven't heard specifically about sesame oil, but I think the same things apply for those natural oils.
It makes me hungry.
So yeah, you know, no, but I don't think it's bad. You know, yeah.
Where do we get, who do we ask for lidocaine?
So this is a prescription. Yeah. Yeah, you're probably oncologist isn't going to know what the hell you're talking about. But this is the reference. I would suggest, and if you guys want, just email YSC or email House of Volta, and I'll provide the paper to you so you can take it to your oncologist. This was done in you. It was done in women with breast cancer who were having vestibular tenderness. This is a study from you.
I can't have lidocaine at the dental office. Is that totally not related to having it?
What happens with it?
My heart races from having it.
Oh yeah, so lidocaine in your dentist's office is applied with a shot, right? Yeah. So this is yeah. No. Don't quote. I mean, I don't know if you should see your cardiologist about before, but typically I don't ask about a heart history when I'm applying this. Yeah. Okay. Question.
I have a tube of lidocaine that they have the iodine for it.
Yeah. It's not. No, so this is not the port lidocaine because that's a cream, right? It's a cream. This is not Emla cream for your vagina. No. It's a liquid. It literally is liquid. It's like water almost. That's why you can saturate a cotton swab. And it's dilute. So no, this is not Emla cream for the vagina. No. Okay.
Does it rub off on your partner?
No, so that's right. So they did query the partners about anesthesia. So no, it doesn't. Yeah. All right, any questions? This is incredibly effective. I can't stress that enough. Question?
So, like, what, are you supposed to lubricate first, then lidocaine, or lidocaine, then lubricate?
You lidocaine, then lubricate. And when you lubricate yourself, lubricate your partner, lubricate your toy, and lubricate liberally. Okay?
How long would that last?
I mean, it lasts as long as you're having activities. Now, if your activities go on for hours, I'm not sure if it's going to last that long. But good for you.
So, like the vaginal ring's kind of like a sphincter muscle.
It's a
And
sphincter.
then once you get it to relax,
Yeah.
it's not gonna like clamp back down. 'Cause
It's not.
It's like it will open up and like kind of stay there.
Yeah, you're getting your vagina drunk a bit. I think it's, yeah, sort of, if you wanted to know, it's kind of getting it drunk a bit, But, yeah, or you loosen up. It's okay,
But if you
it's about
don't
that.
talk to her, like I always tell my husband, she and I don't talk. Like,
Yeah.
like if she looks like she's happy, like I don't know.
Yeah.
Like,
Well, yeah,
so,
I mean,
like,
it's not like this,
oh,
dear diary,
Yeah.
it's not that. But just realize that there are things that we don't control. We don't control our heart rate, right? You don't control spasm. Okay, you can't control why your vagina hurts so much, because you know what's doing that? The aromatase inhibitors, the tamoxifen, the chemo. We changed your vagina, right? So it's nobody's fault. Yeah, absolutely not. But if you didn't understand this, think about what your partners don't understand, okay? Because nobody tells them this anyway, okay? Right? Yeah, preach, yeah, okay, good. So the problem with vaginal lidocaine is that if the problem is with every thrust, it's torture, all right? That's not going to be fixed by vaginal lidocaine. That's a term of vaginismus. That's smooth muscle spasm within the vaginal vault. And I can actually detect this using a pelvic exam. So if having a speculum examination is the most horrendously torturous thing you have done, you might have vaginismus, okay? Same thing. If with each thrust it hurts, the more you continue to subject your vagina to that, the worse the spasm will get. You cannot get her to relax. Neither can your partner, okay? But we can treat that too. So the whole concept of vaginal dilators, which go from an extra small to a large, is to convince your vagina that A, penetration doesn't have to be torture. B, you're going to take care of her. By C, controlling the penetrative experience. Okay? As opposed to vaginal lidocaine, these can be introduced as a toy for a couple. Okay? So for women who have sex with women, okay, this is something that I absolutely would talk about if it was part of your repertoire. Okay? All right? So there are two types. The ones on the left, these ones are more like candlesticks. They're very hard. I've had very little success getting women to do this. These are called biotech dilators. They have a bit of a head on it. It's made of silicone, so it's a little bit more pliable. And here's the instructions. Use it in the morning. Why do I say use it in the morning? It's because if you're like any woman across the United States, you're probably a multitasker, right? So at the end of the day, after taking care of the kids, taking care of the home, going to work, walking your dog, all sorts of things that we do, the last thing anybody wants to do is lie on a bathroom floor with a dilator, trying to convince their vagina that this is okay, all right? You'd rather reach for that bottle of wine, a little bit of stick of marijuana maybe, Netflix and chill, and screw the dilator, right? But if you do it in the morning, it becomes a part of a routine, okay? So before you shower in the morning, before you get dressed in the morning, you do your dilators. And then you can shower and put it away, okay? Important too, start with the smallest size that you think you can do, all right? And give me the mic. Well, no, I don't want to turn it on.
okay.
All right, so if this is the dilator, right, and we're using these ones because it has a head, you're going to hold the dilator close to the front, and you're going to insert it into your vagina, and you're going to stop for pain. You're not going to push through pain. That's not going to help anything. And I'm not giving you a gold star if you go through this whole thing quickly, okay? So you're going to stop once it starts to hurt, and you're going to back off a little bit, and you're just going to hold it there, count to 15, and you're going to put it away. And you will go off with your day, and then maybe 2 days later, try it again. all right? The whole point is you're controlling the penetration, okay? If you want to do this in front of your partner, I encourage it. But if you want to do it alone, that is absolutely okay, all right? Okay? And what you're going to find is with time, your vagina will accommodate a dilator, okay? Because unlike some of my patients that see me who've had pelvic radiation, you don't have to worry about the vaginal walls sticking together, which is a complication of pelvic RT. You can actually lose the vault. You don't have to worry about a use it or lose it phenomenon either, okay? So you can reclaim this, and I would say once you get to the medium plus, or the third one in the row, you can attempt intercourse. My advice is to precondition your vagina by using that or having your partner use the dilator on you and then have intercourse. That's important for two reasons. One, it will show your partner the speed by which penetration is comfortable, all right? And it may even show them an angle where it's more comfortable. And then the third piece of advice, I know I said two, but the third piece of advice is do it with you on top. Why is that? Because you can control the penetration better. Okay? I'm not saying you have to do it on top. It's just, it's just a consideration. There's a drug for desire. It's called flibanserin. This works centrally. Yeah. So it's an interesting drug. It was tested as an antidepressant, and it didn't work. But people were having sex. Crazy, right? So, truth, you don't need to be, you can have depression and you can still have sex, right? So flibanserin was not successful as an antidepressant, so it was tested as a hypoactive sexual desire disorder medication. If you look at the press, they'll say the female Viagra, they say. This is a female Viagra. It is not female Viagra. Because you know what? You got to take it every day. That's not Viagra. Okay? It works centrally. It increases dopamine and norepinephrine in the prefrontal cortex. It reduces serotonin, so there's less inhibition and increase in desire. The indication is in women who are premenopausal, okay, to treat something called hypoactive sexual desire disorder. So that condition is where sex feels great, orgasms are happening, everything's working, it's all good, but once it's done, you can read a book for the rest of your life and not do that again. It's like, I don't really care. I don't want to do that. It's fine, whatever. But once you're through it, it's great while you're having sex. But afterwards, it's like, it's just nothing. That's a real thing. It's called hypoactive sexual desire disorder. This is the drug. The reason why you probably haven't heard of this is because it's very difficult to prescribe this medication. That's number one. It requires, I have to be certified to prescribe it. The pharmacy has to be certified to provide it, and then you have to sign a contract with me before you take it. The contract says, I will not drink while on this medication. Yeah. So once I say that, people are like, no. So, and the reason is that the risks, the most serious risks are hypotension, so lowering of the blood pressure, and fainting, okay? I won't go into details about that study, but if you're interested, I'm happy to talk about it later. So what about the Viagra, Cialis, and all these other medications? Do they work? They don't work for women. There's no evidence at all that drugs that help erections in men will help women. All right. The only caveat here is if your loss of sexual desire was due to an antidepressant. Okay. If you can trace it back to that, there's some nice data that Viagra can help there. But the doses to treat antidepressant-associated sexual dysfunction are the doses that we use to treat men. Okay. So it's pretty high dose. What about testosterone? So testosterone's been, it does work in multiple scenarios, okay? So does it work in women, and more importantly, is it worth the side effects of treatment, right? So the reason why you're probably not getting testosterone for sexual health is because there was a clinical trial in women with cancer, and it didn't work. So compared to placebo, there is no effect at all on sexual function. So this is why you won't hear me prescribe testosterone. So finally, I think we're getting to the end here. A bit of advice for the couple and how to move forward after breast cancer. This is probably the only time, but I've started doing this more regularly. Have the conversation about what the experience has been like, all right? Because we don't provide a voice for that. We actually don't tell folks to talk about it, because I can tell you that cancer is a social disease, and the experience you've had with your loved one, whether it be your partner, but this applies if your mother or your best friend was giving it to you. It's a very scary experience, and I want you to give voice to that. For now, if this is a place of difficulty for you as a couple, adopt a language that cannot be conceived as blame, because again, there's no one's fault here. So the words I actually ask you to use: what do I want? What do I need? What do I wish we could do? All right? That's really important, because it's a way for you to clarify things and own your feelings. All right? It's not about you're too big or you're too fast or you just care about that. It's more about, this is where I am. This is what I want right now. I just want you to hold my hand. I just want to be able to sit on a couch and kiss and not have the expectation that then the shirt's coming off and then we're off to the bedroom. I want us to break that pattern. I need that. Okay? It's very powerful words, and your partner will have his own wishes, wants, and needs. And you'll be surprised. Some of those wants might be, I want to be here for you. There is something called sensate focusing, which essentially takes that term intimacy and puts it into the realm of play. So this is the advice I have for couples as well. Play. Rediscover play. Rediscover why this is important to you. It's not because this is the foundation of marriage and it's what's expected of husbands and wives or wives and wives or anything like that. It used to be fun. So sensate focusing is just a way to play. So it's 4 stages, okay? It's you sitting across from each other, fully clothed or naked, all right? And you take turns touching each other. It could be sensual, it could be playful, it could be to make you laugh, and it's a place for both of you to be vulnerable, okay? So do it clothed, take your time with it. It's one after the other. You shouldn't be talking through it, because it's all about being in the moment of feeling, listening, and noticing, okay? And as you go up these stages, only until the very last one is sexual activities allowed. So it doesn't mean if, you are just incredibly turned on, but you're only in stage 1, go off and help yourself. Help yourself. He can help himself. But the whole point of this is to really separate intimacy from intercourse, okay? It's really to focus on playfulness. It's really to allow yourself to figure out what feels good after breast cancer. Because cancer is a source of distress for everybody. And I actually am getting to the sense that partners are discovering a new normal as well through this whole process. And it's a point where adaptation has to happen. So all of those dreams you had as a couple, they're challenged, and sometimes they're changed. We want to give voice to that, because it's also important. So here, just the whole point of this slide is to say, intimacy matters, and you're right. It does matter, because that's the biggest defense to stress.
Intimacy is a defense against everything that life throws at you. If you don't have that now, you can regain it. So here it is, the 4 stages of sensory focus. It's non-sexual touching. At stage 2, you introduce your chest into the touching phase. Stage 3, mutually touching each other. And stage 4, it's all of those stages you allow for intercourse. Go slow, be deliberate, kick the kids out of the house, go to a hotel, but make it private. And don't do it when, I have 5 minutes, let's sensate. No. All right? This is something, it's supposed to be something you look forward to. That's what I want for couples to experience. So if you're single, there's something called the sexual self-schema, and it's going to shift. Your schema is how you view yourself as a sexual human being. And it's influenced by absolutely everything in your life. Your culture, your religion, your society, your neighborhood, your best friends, okay? And it's individual, and it's going to be challenged, and it may even change. So discovering what your schema is now is a process of rediscovery, and it shouldn't stop you from having your own sexual health today or in the future. Again, counseling advice. Practice is important. Okay, learn your body. All right? And rediscover that. Rediscover your sexual self. Instead of being the student trying to find out what feels good to me, tell me what feels good to me. Teach yourself what feels good to you. Okay? If you're a lesbian or gay or bisexual or transgender, recognize we don't have the tools to help you. Right? There's no evidence basis out there for the LGBTQ. Realize that doctors have their own discriminations and assumptions. Women who have sex with women don't have penetrative intercourse. There's no penis, so there's toys, isn't there? Yeah. So sometimes having that best friend, having your partner ask the really sensitive questions, or if you don't want to do that, just ask, where can I go for this information? It's available nationally, but on a lot of centers it's not. So find a provider to talk to. Realize it may not be your primary team. Include your partner, because sex is a social experience. So here's my conclusion side. Communicate. All right? Tell your partner, tell your team about side effects and symptoms as they relate to vaginal sexual health. Seek help. All right? If you cannot have intercourse right now, work with your partner. Talk about what your wants and your needs and your wishes are. Find compromise as you recover, and then be clear about what that is. After cancer, everyone deserves a sex life. Not everyone needs a sex life, all right? But you deserve it if you want it. That includes the young adult, the older patient, patients in relationships, patients without a partner right now, LGBTQ, patients with advanced or metastatic disease absolutely deserve this. And so does your oncologist. All right. Thank you very much.